I sort of see two main areas where I'm hoping that the treatment of head and neck cancers will advance. One remains in the recurrent metastatic head and neck cancer setting, where immunotherapy has really changed the way that we've approached these patients. We know that there's a number of patients that do quite well with immunotherapy-based treatment, either alone or in combination with chemotherapy. Yet for patients who develop either primary or secondary resistance to immunotherapy or chemoimmunotherapy, there remains a great need for improved therapies in this setting. There's a number of different immunotherapy combinations that are being evaluated, a number of which that have demonstrated early signal, but need to really be validated across in a randomized setting to show that there's a benefit for patients. But I hope that with novel immunotherapy, that we'll be able to overcome some of the resistance to head and neck cancer. The second area is really the question that has been touched on in this meeting as well as in other meetings, which is how do we bring immunotherapy into the curative setting? How do we translate the improvement in survival that immunotherapy has brought for head and neck cancer in the recurrent metastatic setting and translate that into improved outcomes in the curative setting, which is where we do see most of the patients? Of course, the avelumab study, the Javelin study was a negative study. The PembroRad study, which randomized patients to pembrolizumab radiation versus tuximab radiation, was also a negative study. I think the question of how we incorporate immunotherapy, whether it's in the neoadjuvant or induction setting, or whether it's in the adjuvant or post-definitive treatment setting, will be important moving forward, because I'm hopeful that we'll be able to translate some of these benefits in the recurrent metastatic setting with immunotherapy into the frontline setting.